Hey there, and welcome to this episode of the OncoPT podcast. In today's episode, we have a first. Now, I don't know about you, but when I graduated physical therapy school, I had a pretty good idea of the different settings that a physical therapist would work in. But I did not have on my PT bingo card the emergency department. And in fact, this is a very growing area in which physical therapists have a major role to play. And so I turned to one of the leading experts in this super subspecialty within physical therapy, Dr. Rebekah Griffith. So, Dr. Rebekah Griffith, welcome to the OncoPT podcast.
Thank you. To be honest, I probably didn't have oncology PT on my PT school bingo card.
Same. I mean, except I was obsessed, so I did, but...
And just to be like completely transparent, I do work in an acute care hospital and have worked on the oncology floor many, many times. And I am the worst at that. I'm like, oh gosh, you don't feel good. Please let me get you an extra blanket. Like let me tuck you back in because I cannot with
Rebekah.
This. I know. So that's what you do. That is not where you want me. In the emergency department, if you're screaming, you're in 20 out of 10 pain, like I'm your person. I'm like, let's fix that. If you are a little nauseous after chemotherapy, I'm like, oh God, I don't know how to help you. Let me tuck you back in. So I think it's good that there are different specialties. But I'm going to challenge you a little bit in that when we talk about emergency department PT as a subspecialty, I would say we're very much specialists at being the best generalists.
Totally. Well, I mean, I'm sure we'll get into some of the diagnoses you see in the emergency room, but, it's funny because I feel like I would be the worst emergency department physical therapist because, like, that 20 out of 10 pain, I'm like, I'm so sorry. Like, I can't do anything about it. So I think we exist in our own areas because we have found that works really well with us. So can you tell me, because we were talking about on our PT bingo cards, did you graduate school and you knew you wanted to go into the emergency department?
No,
how did
absolutely
that come
not.
About?
No, when I graduated from school, I was like, how in school they have you make like your 5-year plan, like who you're going to be and what you're going to do and how you're going to grow up. And I'm a planner, so I was all about that. I had this whole career path for like 25 years, like mapped out, and I was going to be a brain and spinal cord injury specialist. Mm-hmm. And I did. I started my career at Craig Hospital in Denver, and I loved it. I loved the patients. I loved the people I worked with. But then when I had kids, I was like, man, I just don't want to work full time. Like, this isn't a vibe. So I was like, what am I going to do next? So then I started doing a lot of different per diem things. So I worked per diem at Craig still. And then at an outpatient orthopedic chain physical therapy place, I was like their substitute teacher. I traveled all over the place, like picking up shifts for them. And then I also, a friend of mine from PT school was like, hey, you should come do per diem at our hospital. Now, I have to tell you, like, I never did a clinical rotation in acute care. I was one of those people that thought acute care therapists just walked people up and down the hallway. I was afraid of bodily fluids. Like, literally, if I had to visit a family member in the hospital, I would be, like, sweating because I would be afraid somebody might vomit somewhere in a 2-mile radius. So at that time, I interviewed for the job and I was like, well, okay, like, I'll give this a shot. That the pay was good and my colleague who worked there was great. It's a wonderful facility, so I gave it a shot. And then pretty soon I gave up my other per diem jobs because I really enjoyed what I was doing. And then because I was per diem, I was on every single floor. So mm-hmm. That really allowed me to build my skill set, except evidently in the oncology unit. But otherwise, like, I had so many tools to work with. And then what ended up happening, because I was the on-call therapist, was I carried the pager to the emergency department just in case. So just in case there was somebody in that emergency department purgatory where they couldn't quite go home and they couldn't quite come into the hospital, mm-hmm. Could you come down and take a look? And I got to the point where it was like happening more and more, so that like my ICU patients might not be getting prioritized because these patients over here were discharge pending and the ICU patients weren't going anywhere. Mm-hmm. So it was easy to down prioritize them, but that wasn't really fair to that patient population either. Yeah. So then I started looking into it a little bit more, and at CSM there's like a great group of emergency department PTs that meet every year, so I started going to those and just learning more and more. And then as part of my job, when I became like fully part-time instead of just per diem, I looked into, could we do a quality improvement initiative and get us into the emergency department full-time? and just see what happens. And here we are. We're now like, almost 7 years from that time. Wow. And we have 3 full-time PTs in the ED Monday through Friday and 1 all weekend. We're getting close to having 2 on the weekends as well. To the point where, like, if you're not there on Christmas, like, somebody's getting a phone call because they are so used to having that tool in their toolbox in the emergency department. So that's kind of my weird story of how I got where I am and didn't follow my 25-year plan.
It's so interesting that over the course of a relatively short period of time, it went from you being the kind of like the go-to for, getting calls and calls and calls to now actually having multiple therapists who are a part of this. And I'd really love to talk to you about the quality improvement aspect of this actually here in a bit. But I think it just goes to show like how much of a need there is here, which is so interesting to me. So what kind of things are you seeing, or, what kind of patient impairments or complaints are you working with in the emergency department?
Well, everything. I mean, right? Like the emergency department, my favorite thing about it is it's society's safety net. So every single human could present to the emergency department. We don't see a lot of pediatrics because the children's hospital is like a parking lot away from us. Okay. But with access to care issues that we've been having lately, we are seeing more and more kids than we have before, which also not my spiritual gift, but I'm working on it. And I would say that anything that could come into the emergency department, potentially we're seeing. If patients only came to the ED for life or limb-threatening emergencies, maybe we wouldn't be so busy. But because of access to care issues, people are not necessarily taking the regular path. Also, there is a whole subset of patients that don't have any other choice than to go to the emergency department for medical care. But I would say top diagnoses, musculoskeletal issues, back pain. I think our facility sees an average of 24 patients with back pain per day, so roughly 8 per shift if there's 3 shifts in a day. And that right there is enough to keep one physical therapist busy for an entire day. If we saw all of those patients, we're seeing a lot of ankle fractures, shoulder pain, foot pain, knee pain, hip pain, like all of those things. But then we're also seeing a tremendous amount of patients with dizziness, patients who are falling at home, people who are fall risk, people who the physicians are maybe just not quite sure why they're struggling, and then we mobilize those patients and we're assessing their vitals and we're like, this is why, because they're hemodynamically unstable with mobility. So lots of things. Sometimes it's like just, hey, like this person just doesn't look great on their feet and we don't really know why. Can you come and take a look? So really all kinds of things. And at first blush, I might look at the console and it might say abdominal pain. And I'm like, why am I getting involved with this? And then a quick conversation with the team and you're like, oh, okay, I can see that this is much more than abdominal pain. This patient is maybe post-surgical and had been taking opioids and not hydrating well and not mobilizing well, and now they're constipated. So they're here for abdominal pain, but they're really like not thriving after this surgical procedure, something similar to that. So lots of different reasons why.
When I think of my typical, because I'm very like outpatient, that's been the majority of my career thus far. So when I'm working with a patient, they're usually referred to me or they'll self-refer, and then I do an evaluation on them and then I treat them, and usually my sessions are about an hour. What do sessions look like for you?
It's amazing because they look how you need them to look. So sometimes it's 10 minutes. Sometimes it's 2 hours. Because the goal in the emergency department is for the patient to leave the emergency department. And when I say that, people think that sounds awful, right? Like, my goal is for you to leave. But my goal is to get you to that next step, whatever that next step might be, as successfully as possible. So is that home with home health? Is that to a subacute rehab facility? Is that to an outpatient oncological specialist? Like, who do I need to refer you to and get you to? And what do I need to do to get you there? So if I need to come back and do the Epley maneuver on you 4 times throughout the course of the day because you need a break between each one, or whatever the case may be, then I'm going to do that, because that moves patients out of the emergency department, especially while we have patients waiting to get into the emergency department and there are no beds in the hospital. So if it takes me 2 hours to get a patient to be able to move on to that next step, That's a cost savings to the hospital. That's a huge savings to the patient. They get really like one-on-one personalized care, and it lets us use our skill set, not really bound by like appointment times, and like you can really like do everything you want to do. Obviously within the weird confines of this particularly peculiar structure.
I really appreciate what you said previously about the emergency room in American healthcare is like the catch-all, the safety net for us, like for our people, for our society. And I think we have such an opportunity, like when you explain it that way, it makes sense that, yeah, I'm thinking of the patient who has dizziness and probably has, undiagnosed vertigo that is causing problems. Like, instead of them being admitted to the hospital for, whatever medical things that they may or may not need, imagine the time and the cost that we're saving the patient. But I also have to wonder about, we know that we as American healthcare are struggling.
Yeah.
Understaffed, underappreciated workers, like maxed out on capacity. And so the ability of us as a healthcare profession to get to all of the different patients who need our care, even when it comes to rehab, can be very challenging. And so I'm thinking in terms of, especially in my patients, like the debilitation that can happen with being admitted to the hospital. Like, you're potentially getting ahead of that, which is so cool.
Yeah, and it's not just that. It's like when you think about those studies that show early access to physical therapy can save $2,700 per episode of low back pain. Think about that. If you hurt yourself 20 minutes ago and you came in by ambulance, and I can tell you right now it's safe for you to start moving, I've saved you missed time from work. I've saved you some anxiety. I've empowered you on what to do next, and I've connected you to early access physical therapy follow-up. So not just reduced hospital admissions, also like our patients who we're sending directly to subacute rehab because they're really not thriving at home. Hopefully that patient now missed a debilitating fall. They missed having a subdural. They missed like being found down in their home. Hopefully those are all things that were making a big difference. And then sometimes I see patients who've waited so long to get care, or they have some kind of new neurologic diagnosis, or they've just experienced a massive trauma. If they don't need to sit in the hospital for 3 days and I can send them directly to acute rehab, I'm all for that, because then they're not exposed to other sick patients. They're not spending 3 days in bed. They're able to just get up, get going, and like skip that unnecessary step and get moving forward. And I think one of my biggest soapboxes is that our healthcare system is so downstream.
Absolutely.
And really, like, we're catching people as they fall off the waterfall, and we're missing a lot of them. A lot of them are just falling all the way down. And in the emergency department particularly, we're like at the bottom of the waterfall. But if we as physical therapists in the emergency department can get upstream a little bit and keep some of these patients from going off the cliff, that is a worthy effort. That is absolutely worthy of our time and our effort, especially as we think about our like vision and mission to like transform society. So we need to be where society needs us.
Can we talk a little bit more about the quality initiative that you did? And I'm going to bring that full circle here in a bit, but I think a lot of therapists, even in oncology, and I think this is where we can really take a page out of Rebekah's book here, is we know there's a need. We know that in general, and I say this like we as a society, we as healthcare administrators, we understand there's a benefit, but sometimes the connection of how this benefits the patients, the community, and also the bottom line is not well connected. And sometimes like our very outpatient ortho mill model drives whether or not cancer rehab is implemented well into like just healthcare period. And I bring this up because I think we have a lot to learn from what you did with the quality initiative. So can you talk us through this a little bit, please?
For sure. And I think the biggest thing is solving a problem that's not just rehab based, and solving a problem that isn't just focused on the patient. And I know that sounds like counterintuitive, because all we want to do is give people the best rehab that we can and solve everything we can for the patient. But in order to do that, we need to also solve some issues within our healthcare system, because if it's not easy to implement and it's not sustainable, it doesn't matter if it benefits the patient. If it doesn't work, it doesn't work.
Right.
Like if you're a morning person and you can only work out at 10 o'clock at night, like that's not sustainable. You're never going to do it. So you need to think of a way to do it in a way that's sustainable and works for everybody, because we aren't in silos. And I think that's a big mistake we see with people trying to do quality improvement, is that I'm going to do this thing that's going to benefit these people in this way. But you have to look at the context that you're in. So for us, in order for this to really work, we had to be able to look at all of the invested parties. And that included the emergency department. Like, what are their goals? What are their pain points? How do we, as physical therapists, the services that we offer, alleviate some of the pain points in the emergency department? And one of that is freeing up the physicians to focus on other needs. One of that is reducing the need for imaging. Another is streamlining the discharge process so that patients aren't getting held up in observation for 48 hours to get to subacute rehab. Mm-hmm. So those are all things that we can address. So you have to present that case like, these are problems that I see that you have. These are solutions that I can offer. Mm-hmm. And these are metrics that I know that are important to you. And here's how I can support that. It's good to have a team of invested parties that can help you anticipate what pushback might be. Mm-hmm. So, for example, one of the things they look at very closely in the emergency department is throughput time. Is having a PT consult going to slow us down? That's something that we really had to look at. Are we slowing them down? Are we speeding them up? And I think in some cases it goes both ways. Mm-hmm. But overall, physical therapy does save time and effort and improve throughput in the emergency department. So those were all really important things. And then really understanding, like, can I actually provide value to the patient in this setting? And how am I going to do that? That was the easy part for sure. And then can I support the physical therapists that are doing this work so that they're not burned out, they're not stressed, they're happy with what they're doing, and they're really able to use their clinical skills. So looking at kind of all of the different shareholders and making sure that you had people represented on a team and you weren't trying to do it alone. Mm-hmm. And then I think the most important thing is really looking at making a solid business case mm-hmm. with objectives that are attainable and following up on that regularly. And at the end, you may have not met those objectives and may have found different objectives, but it's good to know what your end goal is so you can work towards that. Yeah. We just did a second kind of pilot program quality improvement initiative in January of, was that last year? February of last year. It's been like a year, where we put a PT in our fast track area, which is people who are there for like minor things. Okay. But a lot of that's musculoskeletal. A ton of that is musculoskeletal. Mm-hmm. So we just parked a PT right there to have them help manage those patients. And some of the metrics that we looked at were how much time we were taking, because that area needs to move fast. Right. And we were looking at who we were serving. Were we really able to provide physical therapist services to patient population who would otherwise never be able to access it? We looked at patient satisfaction. Were patients happy with this? Because the emergency department is a very hard place to satisfy patients. Mm-hmm. But we were getting like 4.89 out of 5 on our patient satisfaction scale. So what kinds of things could we do? When did we need to partner with our APPs? When were we able to manage these patients independently? Was any harm being caused? What kinds of tests and imaging were we looking for that we needed? Things like that. And so understanding what everybody was looking for was very helpful. Mm-hmm. And I think if you're trying to implement something in this situation, a pre and post survey is also very helpful. Mm-hmm. to find out about your co-partner satisfaction with the work that you've done. Yeah.
So fast forward now, because this was about 7 years ago that this was first implemented. You've now have multiple therapists who are working this. So clearly, the program has grown. But in what ways has the program really solidified its place within the emergency department now?
I think we're just we're part of the culture, and I think to a certain extent we're part of something they advertise to staff when they are to physicians when they're recruiting, hey, did you know we have physical therapists in the emergency department? Mm-hmm. We are helping with research about physical therapy in the emergency department. Mm-hmm. We are also really when the hospital right now particularly is looking at bedlock and throughput issues because there are so many patients and so few resources. They are looking to what can be done to make this better. And so the reason we've kind of upped to 3 people is one for that fast track area. How can we help turn these patients out and keep them from coming back? That's key in that area. If you get an x-ray and send somebody out with a severe ankle sprain and you tell them to come back if it keeps hurting, they're going to come right back.
Right.
If you give them education on how to self-manage that and refer them to a physical therapist, they're not coming back. Then in our main emergency department, how can we clear up space to get these patients moving out as quickly as possible? And then we've got all those patients that are holding in the emergency department because there are no beds upstairs. So those are patients that a physical therapist would see on the floor, but they're not on the floor. So do we wait 72 hours till they get a bed? Or do we have that third physical therapist start working with those patients to expedite discharge plans to see if we can discharge patients from that emergency department setting, even if they're hospitalized? And what can we do to keep things moving? So I think that's part of how we've really solidified that. I think provider satisfaction is huge. Like the physicians and the APPs are thrilled that they can call on our resources. I chatted a physician the other day with a teenager with knee pain, and I just wrote, "Hey, did you need a musculoskeletal expert?" And he's like, "Yes, always. Please come now." So like I think that provider satisfaction is high, and then just really being able to keep the patients very well satisfied. All of those things really cemented our place where we are.
This is so exciting because, again, I think we have seen, particularly over the last few years, how problematic kind of the situation and the wait time and the numbers in the emergency room, emergency department, and the hospitals are. So let's kind of talk about the big old elephant in the room. COVID. Tell me how were the physical therapists involved in this process? Like, what kind of roles? And then, because unfortunately, like, the healthcare status as far as like hospitals hasn't magically cleared up. So let's actually start with there, and then I'll ask some follow-up questions to that.
Sure. So when COVID first hit, like we didn't go down to the emergency department very often. We went down if we were called. We didn't stay down there all day because they were trying to reduce vectors, right? Like they were trying to protect us, and like really they were focusing on like essential need only. And I think that the definition of essential really evolved. Like at that time they were like, we only want the bare minimum number of people that need to be here, and we'll call you when we need you. But we also saw that patients weren't coming for a lot of the same things that we would normally see them for in the emergency department because they were afraid to come to the hospital. So we weren't seeing falls. People were falling, they weren't coming. We weren't seeing low back pain. People were coping with that at home or in other ways. So for a while, it was very weird. And we weren't really needed to help in any other way. But as COVID really started to evolve and people started to come back for those same reasons, we had those people that were already coming to the emergency department, and then we also had all the COVID patients coming. And so as we rode each like really large surge, it kind of changed each time. We were still doing what we needed to do, but we were also doing things that, like, I think, again, on your PT school bingo card, you never thought you'd do. Like, I worked as a vaccinator a few days. I worked as extra hands. So I transported patients. I repositioned patients. I helped patients go to and from the bathroom. I did some triage. Like, there was some night shifts in the ED where the hallways were lined with patients. And I just started at one end and took their vitals all the way down and all the way back up. And then it would be time to start again. And, you know, if that patient, when I had seen them 30 minutes ago, their vitals were, 100 over 80, and now they were 70 over 30, like, I'm moving you to the front of the line. I'm going to find you a space right now. Other times it was like, okay, I don't know how else to help you. You're stuck here on the floor. Let me increase your oxygen because your pulse ox is dropping. So like using those emergency triage skills that we have, that ability to provide care that we have. I mean, EMS would come in and I would help them get patients off the gurneys and put them in a chair because there was nowhere else to put them. So I think those were things that we did. There were times when patients were too sick to get out of their cars, but ambulances weren't running the way that they had in the past. So I would go out to cars and pull patients out of the cars and put them into a wheelchair and get them, even if I had to hold their trunk up in the wheelchair and get them into the emergency department. So in that way, we were just answering the call in any way that we needed to. Were we billing CPT codes? No. Were we working as physical therapists and using our skill set? Absolutely. And I think when we look back on this, if anybody's listening and really wants to write like an amazing article or perspective on this, I think the concept of rehab staff being redeployed is amazing because if you think about it, we're the perfect people for it. We know every floor in the hospital. We know where all the supplies are. We understand the hierarchy and communication chains in every unit. We know how to communicate with patients. We know how to assess vitals. We can mobilize patients. We know how to de-escalate patients. We can reposition patients to help their breathing. Like there are so many ways that rehab therapists, OT speech, physical therapists can really you could put us anywhere and we could provide a benefit and support to patient care. So I think that would be a thing I would love to see, like how rehab therapists really answered the call with redeployment during the pandemic. But as you alluded to, the access to care continues to be an issue. We've ridden out our flu waves and our RSV waves, but it's not just that. It's like, I'm here because my knee hurts and my PCP can't see me for 6 weeks.
Boom. Oh, that's huge.
I'm here because my ACL is torn, but the orthopedist is booked 8 months out. So it's just access to care issues. I had to have a minor dermatologic procedure on my neck. It took me 11 months to get that appointment. So it's everywhere. It's a huge issue. And I think until we can really better support preventative health care for one, so that patients have that. Health literacy for two, so patients can really take care of themselves in a number of situations and understand how to support their bodies, I think. And until we have more healthcare providers, I just don't see that changing anytime soon.
Yeah. And I think that's, again, I know there's going to be listeners who are just like rolling their eyes of like, can we stop talking about it? We can't. Like, we have reached a tipping point in the American healthcare system. We can never go back. No. And I think if we're going to survive it, not just from a survive COVID, but if we're really going to make this a sustainable place where people can come and get help and people can like their jobs in helping these people, we have to really lean forward into this very exciting, it sounds exciting, at least from what you're telling me, exciting and very different way of thinking compared to when we were in PT school and we were talking about ortho and neuro and all of these things, this never came up, but it is so needed. Yeah.
Well, and if you think about it, if your mom had to go to the emergency department with low back pain, would you want her to see an emergency department physician who might, prescribe Tylenol, ibuprofen, and a lidocaine patch, or do you want her to see a physical therapist who can maybe provide relief right away?
Yep.
I think the other issue is that physical therapy access is poor.
Oh my God,
it's really
yes.
poor.
Yes.
I say this all the time, and somebody is going to get really sick of it at some point, but physical therapy should not be a luxury. It should be something that's accessible to people. We need to be where the people are. We need to be there at the times they're there. We need to be affordable so that people can actually access that care. I know that's a whole other can of worms. And we need to be able to see patients when they need us. It shouldn't take 5 or 6 weeks to get in to see an outpatient PT. If I wanted to see a chiropractor today, I guarantee you I could.
Absolutely.
In my area, I could find a chiropractor to probably see me by the end of my lunch.
Yep.
Could I find a physical therapist to do the same? It's unlikely.
No.
And I know people, and I wouldn't even know where to start. So if you don't know people, I think it would be hard.
Yep. One of the things that is really pertinent to oncology right now in my area is there are very few lymphedema therapists in my geographical area. It's already like lymphedema is already very challenging when it comes to finding practitioners to treat. But we're kind of in like a weird metropolitan desert in that. But I bring this up because right now there is a good lymphedema program here in Fort Worth. They have a 3-month wait period. And in the time, so again, thinking back to why does the ER come into all of this? Our patients are experiencing, ongoing lymphedema issues, increased swelling, increased infection risk because it's not being handled.
Right.
And when the person develops a cellulitis infection, where are they going to go? Because also, like, I tell them to go there when they, if we can't have another option, the ER. They are going to the emergency department for this. So this is totally pertinent to the oncology realm.
Well, and those are the patients that I get where the consult says leg pain. And then I look at their legs and I cut off their socks and their legs are enormous. And I think to myself, how does it get this bad? Like, how do you get to the point where it becomes like this? But you saying that, I'm like, oh, that's exactly how it gets that bad. But I will let you know, we have an OT that works in our ED that is a lymphedema therapist now. So
that's amazing.
We've got somebody there looking now, which is amazing. But it's a huge issue. It's a huge issue. The other patients that we're seeing from the oncologic sphere are patients with pain. Like, they're in so much pain.
Oh
and I did an interview with Scott Capozza to kind of figure out, like, how as an EDPT I can help with that pain. And that was a great interview with him. But also, like, can I go in there with my skills and help therapeutically position you? Yes. Can I go in and make sure your function's not declining? I see a tremendous number of patients with like a Guillain-Barré, or not a Guillain-Barré, a glioblastoma.
Yeah.
Who all of a sudden their function is like tanking. And then, it's my decision. Is this person coming in? Is this person going back out? Do they have follow-up? Do they have equipment? And I might be the only person that sees that patient. And there are times when those patients are coming in and it's time to make a decision about hospice. And they may have had a physical therapist this whole time, like walking through their journey with them. But I'm the one who's going to be there that says, okay, like, what do we need to do to get you set up for that at home? Right. How can I help your family take care of you successfully? What's important to you to leave here functionally? Mm-hmm. So we need to partner with experts like you, so that we know best how to serve those patients in some of the most critical pieces of their cancer journey.
Yep. And again, I'm thinking about how many patients of mine over the years have gone to the ER because they fell. And, God forbid they have a fracture or they've seriously injured themselves. Like, I've had patients who have presented to the ER because they were experiencing, like, I have this one patient who I'm thinking of in particular, was out playing with some friends and felt and heard a pop in his back. And lo and behold, he unfortunately had a pathologic fracture from undiagnosed multiple myeloma, and then was admitted immediately to the hospital, et cetera, et cetera. Like, this, ideally, we're not seeing the crossover of oncology and ED in the perfect utopian world, but that's not the reality.
Yeah.
And it happens actually pretty commonly, even for the oncology patient population.
Yes. I think, too, just we might be that PT that's finding those things.
Absolutely.
So I've had several patients where I've done an exam and I've been really concerned and we've like pushed for a bigger workup, and then it turns out they do have a new diagnosis of cancer. Mm-hmm. Or like... when you say a pathologic fracture, I had a patient who was there for low back pain, but like it did, like the whole exam did not add up. Yeah. And she ended up getting an abdominal CT based on the abdominal exam that we did. And she had peritoneal cancer that she was unaware of that had actually metastasized from a non-healing skin wound elsewhere. And the next met was a pathologic fracture in her low back. And she had like made it to this point where she had mets kind of everywhere and had no idea. So it was really like, we're consulting you for low back pain. Now we're consulting you again for fracture care. And next we're going to consult you for a possible like placement situation based on the patient's function. So, it's a very, we see everything.
Yeah, absolutely. So I can already hear some people asking the question in their head, I feel like red flags would abound in the emergency department.
Oh, yeah.
So can we talk about how, we learn red flags in school about when it is not appropriate for us as the musculoskeletal movement professional to treat patients. But I also learn as an oncology physical therapist that not that the red flags don't count, but there's sometimes different ways that we approach red flags, or there's even other red flags that we have to be aware of when working with the oncology patient population. Can we talk about red flags and being an ED PT?
Yeah, so I don't know. I feel like in the emergency department, there are very few red flags and everything's pretty much a big yellow flag. Because I was just talking to somebody else about this, like, things that we were taught to send patients to the emergency department for are not actually emergencies. Like when we talk about like high blood pressure, I totally understand why all of those guidelines exist. But if you send a patient in with 210/180, the docs are not really that worried about that. And I'll say, oh, like I remember the first time that I was like, oh, I'm sorry, I can't mobilize that patient. Their blood pressure is too high. It's contraindicated. And they said, what was the patient doing before they came in here? I was like, well, grocery shopping. They're like, uh-huh. And I'm like, huh. And they're like, and what were they doing, the week before that? I'm like, I don't know, just like living. And they're like, right. So they live with this blood pressure. This is not a new blood pressure for them. Mm-hmm. Like, we're not going to manage this today. Their PCP is going to do that. I would like you to get up and stress the patient's system a little bit and see what happens. If something bad happens, then that's part of our workup. Right. We need to know. But you, the movement expert, leaving that patient in the bed helps nobody. Mm-hmm. Because then we don't know what happens. And we need to know what's going to happen. I want you to get that patient up and moving. And then after that, I was really like, oh, that's a mindset change. Mm-hmm. So I need to push your vitals. I need to see what's happening to you. This is a safe environment to do that. Obviously, you're taking into account like the whole picture and the patient's symptoms and their medical stability, like all of that. But again, if that patient has baseline uncontrolled hypertension, we're going to get them all the resources they need for that. But I need to find out if the red flag is waving. Mm-hmm, mm-hmm. They've got the red flag. They've got the hypertension. But is that flag waving? And are they safe to go up and down the stairs? Are they safe to walk out of here today or not? Yeah. And I think that makes us part of the diagnostic workup and less of this like consultant. So I've also had patients where they have 0 red flags, but like my weird spidey senses are tingling. And I'm like, no, like there's something weird is happening here. Yeah. And we'll kind of make a case for more workup with shared decision making with our medical team, and we'll find something really gnarly because we're the musculoskeletal experts and we know what normal should be. We know how it should react to our intervention. And when it doesn't, that's a problem. Right. So we need to figure out why. And so I think from that perspective, we have a lot of great catches in the ED, which I wouldn't call great catches. I'd call them like results from a comprehensive evaluation by a musculoskeletal expert. Yeah. And that's why we're part of that team. It doesn't mean other professionals are missing those things. It means that we work best as a team to provide the best care for the patient. Yep.
What are some misconceptions about physical therapists being in the emergency department?
As far as like PT's misconceptions or the public, what do you think?
You can take it anywhere you want.
Well, I think some of it is some of the misconceptions that I see from other PTs are that we just treat low back pain or something like that we just see orthopedic things. Mm-hmm. But really, most people, once I explain to them, they're very into it, and they're like, oh, and then they can suddenly see all of these other things that they could and should be doing in the emergency department. I think from the medical team perspective, some of the misconceptions are that we don't have the level of differential diagnosis skill that we do. So once we established that, they were like, great, please practice at the top of your scope and handle absolutely everything that you can. Mm-hmm. Will do. Coming through. Right here to help you. So I think that would be like the biggest thing is I got a lot of you can help with that, or you actually want to see patients with those diagnoses. Mm-hmm. Yes, I do. And then from the patient perspective, I think that a lot of patients that I see have never seen a physical therapist before, because like we talked about, it's a luxury. And then there are other patients who just think, well, I don't need a massage, like I need a painkiller or whatever the case may be. But our doctors do a really nice job of setting us up for success to like combat that. Like a lot of our physicians will say the doctor of physical therapy will see you. They're going to assist with your diagnosis, prognosis, and plan of care. They are the experts in this area. They will help you a lot more than I can. So they really kind of like set that stage and then allow us to really like do our job as best as possible. And I also say to patients like, hey, if you're seeing me, that's a really good sign. That means that you're doing well. That means that this dizziness that you have is likely not something very scary, and we can work through it together. This means that your low back pain is safe, and we're going to get you feeling better. So I think from that perspective, it's easy to manage those misconceptions. And once you kind of show your value, those misconceptions go away very quickly.
Yeah. First of all, I need your physicians to come and like hype me up to my patients before they come and see me, because like that buy-in is tremendous. Huge. But I feel like it is a result of you and your team demonstrating how valuable you are time and time again. And I think that is so critical to really having that truly integrative, interdisciplinary team approach to all of this. Like I'm so excited by that.
Yes. And when you walk into a room with a colleague and they say to the patient, oh, you're in such great hands. This physical therapist is the best. Like, I mean, they probably say that for every PT on our team, right? Like, you're working with Mark today. Mark is the best PT we have. But like that patient's now like, okay, I am safe. I'm happy. If this physician thinks they're the best, they're the best. This is the best possible place for me to be.
Absolutely.
And that just little piece like really sets us up for success well. And sometimes it doesn't, and we have to kind of prove ourselves, which we do anyway, because we have to establish therapeutic alliance instantly. But that goes a long way to make that happen. So I think those are small things that we should do for each other. Like if you're referring a patient to an occupational therapist, I want you to see the occupational therapist. She's an expert in these things. She's the best. You're in great hands.
Yep.
And I hear a lot of people ask me like, well, where would you send your mom to rehab? And unfortunately, I can't make those recommendations. You know, I say, I'm going to partner you with our best case manager, and she's going to walk you through all the options and help you make a decision that feels good to you. So I think, especially when you have patients that are faced with a lot of uncertainty and anxiety, and the emergency department is like number one for that. How can we allay your fears, make you feel safe, connected, and well supported?
Even from someone in the healthcare field, like I went the last time, thankfully, I've been to the emergency room was several years ago, pre-COVID. I had this infection that would not go away. And so I was like vomiting nonstop at home. It was awful. But like the instant that I finally got there, you know, got checked in, everything, and, you know, tests came back and they said, we know exactly what this is. This is exactly how we're going to treat it. Like, we have a plan for this. That feeling, even as someone who's like pretty well educated in my own body and functioning, when I had that assurance of, this is the plan and this, like, you are in the best hands possible. I mean, the anxiety that just like washed away was tremendous. And so I think we have such an opportunity as physical therapists in the emergency department to really serve as sometimes like not an explanation, but a solution sometimes to what is going on when sometimes these patients are at their most vulnerable, and knowing that they are in good hands, like,
to be able to leverage our patient education skills in these critical moments in somebody's healthcare journey is amazing. And one of the things I say all the time is, it's safe for you to move. I just want you to know that I know you feel really horrible, but I want to reassure you, it's safe for you to move. It is. Like, people are so relieved just to hear those words. Are you sure? Yeah, you're not going to damage yourself any further. Or you're not doing any damage to yourself.
Yep.
I know it feels scary, but the pain you're feeling right now, I wouldn't want to be feeling that either. And we're going to do everything we can to decrease that. But let's just have you know that it's safe for you to move and that everything is okay. It does not feel okay, but it will be okay. And obviously I don't say, hey, you're okay. I don't say it like that, but to be able to hold somebody's hand who's hyperventilating and terrified that they're never going to be able to go back to their job or they won't be able to pick up their baby. In that moment where they're in the worst case of what if. All of my patients are on the what if spiral. What if I can't walk again? What if I can't go home? What if I can't ever live by myself again? What if they send me to a nursing home? What if my dad, didn't survive that car accident? What if I can't play? I had a kid the other day who's what if I can't play for my team now? Am I going to lose my scholarship? I have military personnel. What if I can't go on my deployment? What if? What if I lose my job? So many things. So to be able to use those patient education skills and bring people back to what is happening, not what if not what if, that helps people really take it down a little bit.
Yeah.
And help them regulate their nervous system and reduce that pain response. And if we can do that really early and give people the skills to do that, I think that's critical. And then anything else I do is just gravy, right? If I can do manipulation or dry needling or give them some exercises or teach them how to use a walker, that's gravy. But if I can make them feel better, more confident, and safer, I'll take that every day. I know we don't have a CPT code for made the patient feel better about life, but we should. I call that therapeutic functional activities. I don't know what other people call that, but that's what I call that. Neuromuscular re-education. I don't know. What do you bill for that? But it's the value that we add in that case, especially in the emergency department when people are buzzing in and out. Yep. You might see a physician in 5 minutes, 10 minutes, what? If you get to spend 30 minutes with somebody telling them all the what ifs you're afraid of while that person helps you navigate that and make sure pain feel better. If all of healthcare was like that, I think we'd be in much better shape.
Oh my God. Absolutely.
But we have payer-centered care and not patient-centered care, so I don't know that that's going to happen anytime soon.
So you wrote a book.
Yeah.
You're not just doing the thing, you're also sharing how other PTs can be doing this. Let's talk about your book.
Well, so my goal in starting this business last year was that I really want there to be a physical therapist in every emergency department, every urgent care clinic. And my goal is to make PT in the emergency department well-known and well-practiced so that people can thrive in this practice setting. Because as you said, it's not even on the bingo card. So I want students to know that they can practice in the emergency department. I want students to know really they can practice anywhere. Let's put on our innovation caps and think about where society needs us and let's get there. And the ED is one example of that. I want clinicians that practice in the emergency department to have access to high quality education to help them thrive in this setting because there's not that now.
Right.
And I want people who are thinking about how to set up an emergency department PT practice to know exactly how to do that so that it's not this trial and error. It's not this started, stopped. It's not a failed program. I want people to be able to start this practice on target and thrive. So the book is called Top of Scope, Emergency Department Physical Therapist Handbook, so that people can pick up this book and know why we should be there, how to do it, what barriers there are, how to overcome that, and then here's a bunch of resources and references for you to use as well. And I just thought, if I can put it down on paper in a simple way, it's not too long, it's only 120 pages, to help you be able to pick it up and then run with it, then maybe my goal of having a PT in every emergency department can come a little bit closer every day.
That's awesome.
Also, if you just want to do a QI initiative, it's a great book for that too. The ED would just be the example. So if you're hey, I want to start this new oncology practice, I would still recommend the book. I'd recommend that top of scope mindset and seeing step by step, this is how you can implement something like that.
Right. And I, as someone who is primarily outpatient, I think that is something that I could really benefit from learning is also first of all, what is happening a little more closely in the emergency department, but then how can I take what is working, because you have been telling us this for the past 45 minutes, how revolutionary this is within your community. Like, how can we then take the lessons learned and the strategies that have worked and then implement that, so we can really, again, this is, at the end of the day, we're all trying to improve healthcare and access for our patients.
Yes.
And I think that is where we in oncology are struggling in general. And I think we have a lot to learn from this implementation.
Well, they're both areas where patients are wildly underserved, right?
Yeah.
And I think they're both practice areas that are going to continue to grow. Mm-hmm. And I think the case studies in the book also highlight so much of where our healthcare system is failing too. So that if you are in outpatient practice and you're like, I'm never going to practice in the ED, I'd encourage you to read it anyway. Mm-hmm. Because maybe you read it and you're like, wow, I didn't know patients were going to the emergency department for these types of things. Mm-hmm. Here's how I can set up a digital triage to keep my patients out of the emergency department. Yep. Or here, maybe I should partner with an emergency department and take some of their referrals. Because we need you to take some of our referrals.
Yep.
So lots of lessons to be learned.
That's amazing. Where can people get your book?
Amazon, Top of Scope, Rebekah Griffith. If you put it in on Amazon, I self-published the book. It is not fancy, but it is hopefully very helpful to you. And you can find it on Amazon. And there's a Kindle format and a paperback format.
Nice.
Yeah.
Oh my God. Congrats. That's amazing.
It is weird to have this book of PT textbooks behind me and have one of them have my name on it.
I think
I'm
that
not
should
gonna
be,
lie, it's a very cool experience.
We should make that more common. I feel like that should be a thing.
I think it's amazing. If you're thinking about writing a book, just do it.
I have one in the works, but I can't say any more about it right now. So
hey.
I'm so intrigued by the self-publishing side of things. So anyways, Rebekah, where can people find you, learn more from you on the great wide internet?
Okay, so we have a website, www.theeddpt.com. If you put in the EDPT, it's a very nice personal trainer in England, and not me. So eddpt.com, and you can find us on Instagram at the EDDPT, Facebook. We have a page as well as a group called the Emergency Department Physical Therapists that you can join and have discussions with other PTs. Mm-hmm. And then Twitter at the EDDPT.
Fantastic.
And that's it.
Oh my God. Rebekah, thank you so much for coming on the podcast today. This was immensely enlightening about a lot of things, and it's really getting some gears turning about what can we learn from this to really help with the access and care, even within, no matter where in oncology you are. There's definitely strategies from this episode that were so helpful. And again, they kind of turned on some cogs turning, which I'm really excited to unpack. So
excellent.